I invite my friend Dr. Krishna. He is Dr. Sri Krishna Vintumurli. He is my classmate and a close friend. He is currently practicing as a nephrologist in Brisbane, Australia. He completed his MBBS from Andhra Medical College and later his MD and DM from the PGMR Chandigarh. He has FRACP Nephrology Fellowship in 2008 and completed his PhD in 2019. He has multiple publications in international journals and is a regular speaker at educational meetings. His special interest is C.K.D. He is the chief investigator for Queensland C.K.D registry and biopsy registry. I welcome him to deliver his talk. Thank you.
Good evening, everyone. It's indeed a great privilege to see so many senior doctors coming to attend a meeting on a Friday. That shows the interest, and I'm really happy that so many of you came to listen to what I say. And thanks to Jawahar, I usually come to Visakhapatnam, that's where I am from. And whenever I come, I try to give some lecture. I was invited to talk. So Jawahar is asking me to come and speak in Kakinada for many, many years. And I thought this time I'll use that opportunity to come here. And it's a very common question that people ask me why you become a nephrologist. Right? Many of you would also have the same doubt why you become a nephrologist. So before I deliver my lecture, I would just like to speak to you, tell you why I became a nephrologist actually. I was doing my MD in PGI Chandigarh, and when I finished my MD, I thought I can do any advanced training. I could be a cardiologist, gastroenterologist, pulmonologist, neurologist, anything. But when you are in doubt, what you do? You go to a senior. So I went to one of my senior residents, and in the hostel, I went to him, and I casually asked him, what should I do at an advanced training? He asked me, said, Krishna, come and sit with me next to. And he said, the most intelligent people after MD will do cardiology. I said, okay, that's fine. And if you are technically brilliant, you should do gastroenterology. I said, that's nice. Then he said, if you have a complex mind, then you should do endocrinology because it's very complex. Then he said, if you are very imaginative, you should do nephrology. You should do neurology. I said, if you are none of these, you should do nephrology. I said, thank you. And I was just started to walk away. Then he asked me, what did you decide? In my mind, I was imagining I'm going to be a cardiologist because I thought I'm the most intelligent guy. But he said, before I left at the door, he said, hey, Krishna, I think you should become a nephrologist. That's how I became a nephrologist. So I'm not the most intelligent, more technically brilliant, more complex fellow, but I like what I do. So that's my profession. And I'm very much interested in C.K.D, which is actually relatively very new term. I mean, many of you, when you're in your student days, you probably never heard the word C.K.D. It is all chronic renal failure, isn't it? So renal failure is considered to be a complication of some condition. If someone has diabetes, hypertension, glomerulonephritis, any other condition, obstructive uropathy, you actually develop chronic renal failure. It's a complication. It's not a disease. But with the advent of EGFR, with the concept of EGFR around 1999 to 2000, C.K.D has become a disease by its own. And it's got international recognition. Then realize that chronic kidney disease is an important disease entity because it's a very important risk factor for cardiovascular disease. A lot of people ask me that, why do you want to treat renal patients? Why do you want to see patients? I am not worried that most of my patients become dialysis dependent because out of 100 patients, only 10% will go to dialysis. The rest of the 90% die of cardiovascular disease. So actually, I treat my patients so that they don't develop cardiac disease. So that is the most important concept. So when you see a patient in your practice with renal failure, don't worry that this patient is going to have dialysis. Majority don't reach the level of dialysis. So the best surviving people will go to dialysis. The rest of them die of cardiovascular disease. So be aware of that. That's the most important. Right? If that is the case, what is the best way to manage them? Until 2010, when I was practicing as a consultant, it's a very simple thing for nephrologists. Okay, cool job. All you do is do a creatinine, see the level, and say that creatinine is either okay or it's been elevated, not elevated, send the patient back. We don't have to do anything. And if they do dialysis, they do dialysis. If they do dialysis, they die in other hands. But in recent times, lot of newer medications have come, which are started to make a lot of difference in the management of chronic kidney disease. Suddenly, the advent of the new medications, what we call as SGLT2 inhibitors, mineral receptor antagonists like the group of medications called phenobarbital, and the GLP-1 agonists like Ozempic, these medications started to enter the field of chronic kidney disease now. And suddenly the entire landscape has changed. So we are trying to manage chronic kidney disease in a better way. So I'm not talking about all the medications, but I would like to just talk about the role of SGLT2 inhibitors, right? You all heard the concept that an apple a day keeps the doctor away. Can anyone tell you why it is the cause? Why? How does an apple actually keep the doctor away? Any of you? Why did the concept has come? Where it has come from? It has come. Yes. Yeah. Sorry. It has come in 1835 probably. The reason is one of the French scientists has discovered that there is a compound called fluorescence from the bark of apple tree, right? And he said that this got anti-diabetic property, 1835, and then people started saying that can you use that bark powder or something like that? How do you manage it? It's not palatable, can't be used. Gastrointestinal symptoms are there. So it took such a long time before it actually became a medicine. So around 2009, 2010, it was discovered that these fluorescents which were there are actually converted themselves into the drugs which we can use. And the mechanism is what we call as sodium glucose co-transporter inhibition. That's why it's called SGLT receptor 2. There are two types of resistor, 1 and 2 types, and it is the main receptor 2 inhibitors. So SGLT2 inhibitors. If I tell you that all of us who are sitting here should take a tablet every day, mix it in the water, take it in the morning, will you believe me? So that's what I believe. So that's the question actually. Is it a myth that everybody should take an SGLT2 inhibitor, or actually is it a miracle medication? Right? Let's just go through some of the data that's been available. Then you tell me at the end, would you still believe it's a myth or a miracle medication? Okay? Let's go step by step. Right. Okay. So I'll just tell you the mechanism of action and then I will go. Although I said my interest is C.K.D, today's C.K.D is different. C stands for cardiology, K stands for kidney disease, and D stands for diabetes. Okay. So my C.K.D today is cardiac, kidney, and diabetes, just not chronic kidney disease. Okay. So I'll just talk about that and we'll have a summary at the end of the day. Okay. They block glucose reabsorption in the kidney, in the proximal tubule of the kidney. As you know, most of the glucose that is filtered at the glomerulus is reabsorbed back by the kidney. 90% of the glucose that is filtered in the kidney, in the glomerulus, is reabsorbed back in the proximal convoluted tubule. And about rest of the about 10% will be reabsorbed down the other tubes there in the distal convoluted tubule. So majority of glucose that is filtered is absorbed back in the proximal convoluted tubule. So this is what, as I can show you that. See, that's basically as you would have seen in physiology. There's a glomerulus there, and that's the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and the collecting tubule there. And majority of the glucose that is filtered is absorbed back, and it is a glucose sodium co-transport. So along with glucose, sodium is also absorbed in the proximal convoluted tubule. So that is a normal mechanism. And this happens because of the receptors, SGLT2 receptors. That's the normal mechanism, right? Right. So if you look at the hemodynamic mechanism of what to happen, so this is the normal picture. What we see is, so you have a blood flowing through the afferent arteriole to the glomerulus, and then you have glucose that is reabsorbed here. So some sodium that comes to the distal convoluted tubule, and as you can see, this is the macula densa. Macula densa is nothing but a pathology lab of its kidney. So macula densa do blood tests of everything and find out what it is entering kidney, what is happening with, and adjust the blood flow and everything there. So it's a pathology lab for the kidney basically. So that's the normal mechanism. But if you see, for example, in diabetic patients, what happens? Because of there is high glucose in the blood circulation, a lot of glucose gets filtered in the glomerulus, and because of the hyperfiltration, so much glucose gets absorbed in the proximal convoluted tubule. Along with that, lot of glucose also gets absorbed. Sodium is also gets absorbed in the proximal convoluted tubule. So less sodium reaches the distal convoluted tubule. So when there is less sodium in the distal convoluted tubule, the macula densa gets activated and says that, hey, what's happening? There's not much of sodium that is coming to me. So can we do something about it? What happens because of that? The afferent arteriole dilates, more blood comes in, more hyperfiltration, and more damage there. So the tubulo-glomerular feedback, what we call, the tubules talking to the glomerulus, is deranged in diabetic patients. But when you use SGLT2 inhibitors, what's happening is it basically blocks the absorption of glucose and sodium in the proximal convoluted tubule. So there is lot of glucose and sodium become available to the distal convoluted tubule. And now the distal convoluted tubule says that, hey, lot of sodium is coming to me. So I don't want so much of blood flow into the glomerulus. So there is vasomodulation of the afferent arteriole, less blood flowing into the glomerulus, less hyperfiltration, and better tubulo-glomerular feedback. Hope you understand that. So the tubules keep talking to the glomerulus always and regulate the flow into the glomerulus. So in diabetes, it is deranged. By using SGLT2 inhibitors, it is rearranged there. So that's the mechanism that what happens here. So when the SGLT2 increase the loss of sodium and glucose, what are the physiological consequences of that? And increased urinary sodium and glucose excretion basically leads to increased glucagon versus insulin ratio. So that leads to lipolysis and improved glycemic control and then weight loss. So that's what normally happens in diabetic patients when you use this medication. And reduced plasma volume because sodium is lost. So there is reduced plasma volume and improved endothelial function that happens there. And there is increased diuresis because glucose is an osmotic agent. So the more glucose is lost in the urine, more water is lost. It acts as a diuretic as well. So it reduced in ventricular preload and better myocardial function. So it has got useful in the heart as well. And similarly, here it is a reduced ATP consumption by the proximal convoluted tubule. So improve energy mechanism and reversion of the myofibroblast formation, and also there is an increased hematocrit value also because whenever there is myofibroblasts are less in the tubule or interstitium, as you know, kidneys produce the erythropoietin to improve the hemoglobin. So obviously the hematocrit will improve. So there is multiple ways how a simple SGLT2 inhibitor will improve health of multiple systems, just not kidneys or diabetes. Okay, so you can see that. So simply as far as cardiac function is concerned, so it improves the myocardial cellular homeostasis by various mechanisms, and it's got electrophysiological effects there, and it got optimizing the mitochondrial energy utilization in the heart muscle, and extra cardiac mechanisms are there as we discussed: reduce blood pressure, improve renal function, reduce hepatic steatosis, and stimulating erythropoiesis, and optimizing the myocardial oxygen and supply demand, and improving microvascular circulation in the heart muscle itself, and attenuating the inflammation. It's an anti-inflammatory too. So when it says that it is useful for heart condition, it is just not by diuresis. A lot of people think that, hey, it's a diuretic, so because there is reduced volume load, cardiac condition is improving. Just not that. There is multiple mechanisms by which SGLT2 inhibitors actually improve the cardiac health. And just don't think about cardiac health. Now, if you, as you move on into the future, in the next 3, 4, 5 years, you are going to find that SGLT2 inhibitors are useful at multiple disease mechanisms. You can see that with regards to pancreas, it is better glucose control, reduced insulin resistance, optimizing the hemodynamic effects, and lowering the free radical generation and antioxidant capacity. So it's useful for diabetes. And as I said, it is useful for heart conditions. And it reduces the albuminuria, reduce the tubular injury, and suppress the oxygen radicals, and reduce renal interstitial fibrosis, optimizing the endothelial function, and improve mitochondrial function in kidney. Then if you go to the liver, it is going to normalize the liver enzymes, ameliorate the fat deposition, attenuate the fibrosis, reduce oxidative stress in liver. So it is probably going to be one of the drugs that is going to be used in hepatic steatosis, especially non-alcoholic fatty liver. In fatty liver, very soon SGLT2 inhibitors may be actually becoming drug of choice for fatty liver too. Not only that, if you go to the circulation, central circulation, it is going to have similar effects with the cerebrovascular disease and may become an additive medication for cerebrovascular disease too. And again, if you go into that, because the reduced free radical production and inhibition of tumor neorevascularization, maybe it is going to act as an anti-cancer medication. So it is a diabetic medication, it's a cardiac medication, it's a renal medication, it's a liver medication, it's a cerebrovascular medication, and it probably is an anti-cancer medication. So that is how the spectrum is evolving, and we already know the benefits in the first three. Like we know the benefits as far as cardiac is concerned, we know the benefits as far as kidney is concerned, and we know the benefits as far as diabetes is concerned. The rest are coming with other studies will be published very soon. So the primary goal, so when I say cardiac disease and when I say kidney disease, when I say diabetic disease, all of you know that these are inseparable. You will never ever see a cardiac patient without other conditions. Either patient is diabetic or patient has chronic kidney disease. In fact, if you go into any cardiology clinic and do EGFR for these patients, at least 70 to 80% will have kidney disease, undiagnosed. Because cardiologists will put a lot of stents, they are not bothered about creatinine, but every cardiology patient has kidney disease behind them. That's a very important thing, right? And most of our patients are diabetic too. So these three are inseparable. So whenever we want to treat these patients, either kidney patients or cardiac patients or diabetic patients, please think this as a spectrum, and we want to treat all these three conditions, but just not alone. So that's what it is important because of this combination. If you look at that, C.K.D plus CBD is combined. C.K.D is only C.K.D is, for example, only just 5% because it's always mixed with cardiovascular disease and diabetes. So most of it is the time it is the spectrum of the disease combination rather than single disease entity. That's the important thing. And when you come to cardiology, cardiac disease, for example, so these SGLT2 medications, it's a very interesting concept. So these started as a diabetic medications in around 2008, 2009, 2010. But what happened was any new diabetic medication that come into market, any new medication that will come into market should be tested for cardiac complications because of FDA guidelines. Because you know those previous medications called glitazones, people must have used rosiglitazone and other medications. They are the diabetic medications. They were introduced into market. They became very popular. We were all using them. Suddenly what happened? After post-market, it was found out that they cause heart failure. So these medications were withdrawn from the circulation. So FDA has learned its lesson. So what it said is, any new diabetic medication that comes into practice, the companies should do cardiac studies, and they must prove that this medication has no cardiac side effects. So that is how the companies started doing studies, research studies, just to satisfy FDA guidelines. They are not done with any intention that they are cardiac medications. That's how it all started. So they have multiple studies, Declare TIMI study and EMPA-REG study. Declare is basically dapagliflozin, EMPA is empagliflozin, and Canvas is cangliflozin. So these are the three main medications which are available. So that's why each company has used their own medication to do the study. Right. And most of the time it's diabetic patients. So you can see that HbA1c more than 6.5 and less than 12, age more than 40 with established cardiovascular disease, or age more than 55 with a traditional cardiovascular risk factor like dyslipidemia, hypertension, and current smoker. And similar, very much similar presentation for these three things as well. So in the DECLARE study, basically what happened, there's about 17,160 patients, all type 2 diabetic patients, established cardiovascular disease, or multiple risk factors. So they've taken these patients and randomized just dapagliflozin 10 milligrams or a placebo they have used, and then a median follow-up of about 4.2 years, and primary endpoints are basically looking at the cardiovascular disease endpoints there. So what happened there? As you see that between the placebo and dapagliflozin, you can see the separation of these two from very early days. So from 180 days, 360. So you can see that it's been separated very early. And so basically around it's around 20-25% reduction in the cardiovascular endpoints. It is cardiovascular disease and heart failure. MACE is major adverse cardiovascular. It's a combination of factors. And again, you find that it's very useful. The curves started to get separated. So what the companies found is, instead of finding that there are cardiac side effects, they found that these medications are actually beneficial for heart patients. So it's a reverse. So the companies, the major shareholders' eyes became very bright. They said, hey, we started a diabetic medication, suddenly looks like it became a cardiac medication. And then the further studies started to come. So that is basically empagliflozin study there. And again, very simple. Type 2 diabetes mellitus patients with high risk for cardiovascular disease and randomized to receive 111. So empagliflozin 10, 25 or a placebo there. And you can see that with regards to empagliflozin, the is superior to placebo in improving the glycemic control and reducing the cardiovascular events in patients with type 2 diabetes and established cardiovascular disease, and this is including mortality benefit. So suddenly these caught the attention of a lot of people and said, hey, looks like it's becoming a major cardiac medication rather than a diabetic medication. And similarly, the next study has come, Canvas study. It basically similarly showed very similar results, said that useful cardiac medication. But in Canvas study, unfortunately, what it showed, there is increased amputations in these patients. So suddenly the FDA became a bit more alert. Is really SGLT2 inhibitors as good as what the companies say, or are there more side effects? And unfortunately, the Canvas study also showed one more side effect, increased fractures. Increased amputations and increased fractures. So it became a kind of side effect. And the FDA was concerned and said, put it as a side effect, adverse effect, and wanted more studies to be done. Because if you don't want to treat a diabetic patient who has now become an amputee, you don't want to do that. And majority of patients are elderly patients. You don't want to have increased fracture risk in these patients. So that's why suddenly it became a bit of a concerning issue. And now, more recently, the DELIVER study has come, and basically what it shows, it's age more than 40 years, class 2 to class 4, and ejection fraction more than 40%, and structural heart disease. And so basically, again, the primary endpoint, secondary endpoints are the same. dapagliflozin 10 or the placebo that's been used, and it basically showed that it's a very useful medication in improving the cardiovascular outcomes, both in terms of heart failure, both in terms of hospitalization, and in terms of mortality. Right. Because of this, suppose uh, because of all these studies, I've shown only few studies, but there are a lot of other studies that come. Because of all these studies, now SGLT2 inhibitors are considered to be one of the 4 pillars of cardiac management, heart failure management. If you have a patient with heart failure, any of you, irrespective of the ejection fraction, so it doesn't have to be less than 40, irrespective of the ejection fraction, if you have a patient with heart failure, this patient should be on an SGLT2 inhibitor, unless otherwise contraindicated. If you have a contraindication, that's different. If you have a heart failure patient, if he or she is not on SGLT2 inhibitor, you must have an explanation why your patient is not on this one. It became part of every international guidelines, included SGLT2 inhibitors as the 4 pillars of therapy. You probably know the 4 pillars of heart failure management. It is the diuretics, the beta blockers, and it is the SGLT2 inhibitors, and ACE inhibitors or ARNI, what we call as Entresto is the medication. So these are the 4 pillars, and SGLT2 inhibitors have become the standard management in cardiovascular patients, especially with those heart failure. Right? So I hope you have no doubt about if you have a heart failure patient, very useful medication. Okay, now we'll go into the kidney part. Majority of the kidney patients would, as you know, would be on renin-angiotensin blockers. Like you see, most of them are AC inhibitors or angiotensin receptor blockers. Standard practice. Every guideline says that kidney patients should be treated with this. They are the drug of choice. So if you use ACE inhibitors in combination with SGLT2 inhibitors, what are you looking at? So look at the glomerulus there, and the ACE inhibitors or angiotensin receptor blockers basically act on the efferent artery. So that is where they act. It dilates the efferent arteriole and then decrease the glomerular pressure, reduce the albuminuria, and produce renal protection. Right? If you use SGLT2 inhibitor, it acts on the afferent arteriole. When you are using both these medications, both are active. So in a way, so they are acted at different levels, but the purpose is the same, to reduce the intraglomerular pressure and protect the kidneys. That is how it acts in a different ways. So you will be using both these medications. And when you use SGLT2 inhibitors, what is first happens, it's a very counterproductive for a kidney specialist. When I start these patients on these medications, I tell them that actually there is an EGFR drop immediately in 2 to 3 weeks. So when you start a patient with these medications, there is an initial drop of kidney function. So it is not equivalent to worsening kidney function. So it is not equivalent to acute kidney injury. It is what's simply called as EGFR drop. That's all. So when I start this medication for my patients or with the primary physicians, I tell them that tell your patients that next time when they do a blood test, the EGFR actually drops. Nothing to worry about. Okay? But as you can see, initially there's a drop when you use it, but over time it gets stabilized. Whereas in patients who are not on SGLT2 inhibitors, you can see that it's a gradual progressive downwards, right? So there is an initial drop of EGFR for which you don't have to worry about it. As the time goes by, the EGFR gets stabilized over time and there is increased renal protection in these patients. Right. So the first one to prove is C.K.D study. So they used can-gliflozin in these patients. They have taken type 2 diabetic patients with kidney disease and used can-gliflozin there. So what they found out is basically there is about 30% reduction in the progression of kidney disease. So basically it prevent the progression of kidney disease. So improving the EGFR slope or reducing the fall of EGFR in these patients, right? And initially, a lot of discussion happened that is it all because of good diabetic control or SGLT2 inhibitors have anything different? Is it doing something else? As I told you, the different mechanisms. So it is now more clear that it is just not pure diabetic control. It is additional pathological mechanisms by which kidney disease progression is halted when you use these medications. So Canvas is the first one which is proven with diabetic patients with kidney disease. Then you have C.K.D. So they used empagliflozin in C.K.D. patients. What they've done, they have taken half patients with diabetes, half patients without diabetes in C.K.D. So now for the first time, they actually used this medication in non-diabetic C.K.D. patients and given just 10 milligrams of empagliflozin. And as you can find out, what happened was they got good outcomes. There's about 30% relative rate reduction in fall of EGFR in these patients. And there is obviously improving the primary endpoints there. So the conclusion was among a wide range of patients with C.K.D, either diabetic or non-diabetic, that's the most important thing, at risk of progression, who are likely to progress with kidney disease, empagliflozin therapy led to a lower risk of progression of C.K.D and death from cardiovascular disease. So basically, CKD study showed that it protects the kidney and prevents the cardiovascular deaths in these patients. And similarly, you have a DAPA-CKD study. They used dapagliflozin and it showed brilliant results actually. So when they used it, again, same study, diabetic patients and non-diabetic patients. So overall, it showed almost 40% relative risk reduction of progression of kidney disease. Very rarely seen in any studies. We don't see such brilliant results, right? Almost 40% risk reduction. Then they separated the two groups, diabetic kidney disease and non-diabetic kidney disease. And they found out actually the rate reduction in non-diabetic kidney disease is close to 50%. The relative risk reduction is 50% in non-diabetic kidney disease. So once these three studies, the DAPA-CKD, EMPA-CKD studies were published, the international guidelines have changed. Now, SGLT2 inhibitors have become drug of choice in all CKD patients. International guidelines, either diabetic or non-diabetic. So if you have a patient with C.K.D, chronic kidney disease, and has albuminuria, you will start, or you are likely to, you must start these patients on SGLT2 inhibitors unless otherwise there is a specific contraindication. So there doesn't have to be diabetics. So this has actually become a very good kidney medication. So the initial studies showed it's become a very good cardiac medication. These studies have shown that it actually become a good kidney medication. Now imagine you have a medication which basically started as a diabetic medication, right? So these are the baseline characteristics there. And as I said, 39% rate reduction and 31% reduction in all-cause mortality, 44% renal composite outcomes, and 29% rate reduction in cardiovascular death. So every aspect they studied, irrespective of the GFR levels, is found to be useful. Right. So this is what we call as a heat map in kidney disease. So if your patient is in green, it's a good outcome. If the patient is in red, it's a bad outcome. So these studies, the DAPA-CKD study and the EMPA-CKD study, actually include all the patients across the spectrum of kidney disease, depending on the risk. Because of that, these two medications have become the drug of choice for CKD patients. So all my patients, I use it. I tell all my general practitioners, primary physicians, to start this medication. So if you have a CKD patient, if your CKD patient is not on this medication, you must question yourself, why my patient is not on this medication. Okay? So, as I said, when you look at the international guidelines, for all our patients, we tell lifestyle modifications, absolutely important. In the first line therapy, SGLT2. So, if you have a diabetic patient who is on metformin, if you want to add a diabetic medication, SGLT2 inhibitors. If the patient has CKD, SGLT2 inhibitors. If the patient has cardiovascular disease, SGLT2 inhibitors. So, SGLT2 inhibitors basically come part of guidelines everywhere for these conditions, right? Then you can see the selected clinical trials and inhibitors in CKD and CVD. Basically, look at all the studies. Every study has so far shown beneficial outcomes in terms of cardiovascular disease, in terms of chronic kidney disease. Every study, every study. It is just not one or two. Right. And honestly, these started as diabetic medications. Around 2008, 2009, 2010, you have studies. So empagliflozin, there is a change of HbA1c, reduced HbA1c, canagliflozin, and dapagliflozin basically. So started as diabetic medications, but became a cardiac medication, became a kidney medication there. So that's the timeline. If you look at that, from 2010 to 2016, this is a diabetic medication and a good second line diabetic medication. Especially, it works as a good diabetic medication when the EGFR is more than 45. If the EGFR is below 45, the efficiency of it reduces as a diabetic medication. However, its efficiency improves as a CKD medication. Its efficiency improves as a cardiac medication. But you probably don't want to use it as a pure diabetic medication if the GFR is 30 or 35, right? But it's going to be a useful medication for other conditions. Then what happened? Around 2016 to 2018, it became a cardiac medication. And from 2018 to 2022, it became a CKD medication. So now it became, at the end of 2022, it became a cardiac medication across the spectrum of heart failure, irrespective of ejection fraction. So it's looking like it's covering all the conditions which we generally see in our patients. So this is how we got there actually. Started as a type 2 medication, DAPA, canagliflozin, empagliflozin. Then they started to do the cardiac studies there, multiple things. Define heart failure, decline study, EMPER reduced study there, DAPA CKD study, EMPA CKD study. And as you can see, how it evolved. Multiple studies in patients with reduced heart ejection fraction, in patients with normal ejection fraction, in patients with diabetic CKD, in patients with non-diabetic CKD. So a lot of studies. As you can see that it evolved and they almost become medication, drug of choice in most of the conditions which we treat. Right. And because there's initial EGFR dip in these patients, initially it was thought that in some patients it can worsen the kidney condition. That's why this concept of AKI, does these medications cause acute kidney injury, has come. But in fact, it is the reverse. Most of the studies done afterward showed actually these are a useful medication for acute kidney injury because it improves the antioxidant things. It reduces the radical oxygen free radicals. So, and it improves the oxygenation in the microcirculation. It's actually good for acute kidney injury rather than causing acute kidney injury. So there is no concern for me as a nephrologist that these medications are bad for kidneys in that sense. So they don't cause acute kidney injury. Right. And because I told you, Canvas study has shown increased fractures, only one study. The rest of the studies which come out later never showed this. Only one study. So it could be because of the population they chose, or it could be something specific to canagliflozin, but not to other medications. And as you can see that, so these are the changes that happen when you are using SGLT2 inhibitors there. And none of the studies later actually showed an increased risk of fracture. Right? So this is more towards, if any of the dots coming is more towards SGLT2, and that is more towards no fractures there. And none of the studies actually showed increased risk of fractures. So we don't have any concerns that there is increased risk of fractures in this. And similarly, in liver disease, SGLT2 inhibitors, they reduce the hyperglycemia, they improve the visceral adiposity, reduce serum uric acid, so it's actually good for gout patients too, and reduce oxidative stress, reduce inflammation, increase adiponectin. So it probably is going to become a drug of choice for NASH very soon. And as I said, uric acid metabolism, it reduces uric acid, so it's got beneficial effects in gout. And most of our patients do have gout too, hypertension and gout, C.K.D and gout. And amputations, because again, only one study showed increased amputations, none of the other studies, right? However, you would like to be careful in diabetic patients who have high risk of amputations, like if they have peripheral vascular disease and if they have ulcers and other things, you want to be careful with that. Other than that, there is no increased risk of amputations in these patients. None of the studies have shown that. How? Then there's a recent study that's published showed despite all the benefits that I've shown, still SGLT2 inhibitors use has not been picked up. I think because it started as a diabetic medication, so in majority of physicians, it was stamped as a diabetic medication. But it evolved out of being a diabetic medication and has become a medication of choice with C.K.D, diabetic, non-diabetic, medication of choice with cardiovascular disease, especially in heart failure patients, and of course in diabetes. So almost, I don't know how many of us have these conditions here, but you would see most of our patients actually come to you with these conditions. And when you see a patient with any of these conditions, please go down the medications list and they should be on a SGLT inhibitor. And if they're not, you are saying that why they are not on these medications. All right. So in summary, SGLT2 inhibitors have been successively approved to decrease cardiovascular death and decrease the risk of stroke and cardiac attack in type 2 diabetic adults who have been diagnosed with cardiovascular disease. They are for treating heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, and treat diabetic kidney disease, decrease the risk of hospitalization for heart failure in type 2 diabetes mellitus and diabetic kidney disease. And they are expected to be an effective treatment for type 2 diabetic patients with non-alcoholic fatty liver disease, and they have a similar safety profile to placebo or other active control groups with major adverse events such as ketoacidosis or hypotension or urinary tract infections. I'm very more than happy to discuss any of the side effects in as part of question and answer session, but these actually became medications with excellent safety profile, but very, very useful medications. Thank you. I hope I'm able to convince you that these are useful medications and it's not a myth and it's actually a miracle medication. And maybe many of us get up in the morning, take one tablet.